Thanks so much for having me. It's nice to be here today. So I have a couple of disclosures. There's a partnership between Children's Colorado and the Colorado Department of Public Health and Environment, which is called the Colorado Antimicrobial Stewardship Endeavor. And I'm a PI for a grant funded by Pfizer, and 25% of my current time is funded by the Colorado Department of Health to implement a mobile app. And then Children's Hospital Colorado has a contract with a third-party software system called Agile MD, but I have no personal compensation from that. So as far as today's concerned, I have 3 learning objectives. First of which is to understand the core competencies for researchers and learning health systems, to understand why clinical pathways are a natural intervention for this work, and then to describe efforts undertaken at Children's Hospital Colorado to create a clinical pathways learning health system. So my background, I worked for 5 years as a pediatric hospitalist at Children's Hospital Colorado, and then I had an opportunity to pursue a pediatric academic research fellowship in Toronto, where I earned a master's in clinical epidemiology, where my project was looking at differences in clinical practice guideline recommendations, and then also earned a quality and patient safety certificate. When I came back, I then returned to Colorado and had the opportunity to oversee the clinical care guidelines program, after which a couple of years I pursued a subspecialist clinical outcomes research fellowship and have just recently finished a Learning Health Systems K-12 institutional award through PedsNet. So the first thing that we're going to talk about are learning health system and the research competencies. So as I think some people know, the Agency for Healthcare Research and Quality in 2012 defined learning health systems as a health system in which internal data and experience are systematically integrated with external evidence and that knowledge is put into practice. So that's the nuts and bolts of a learning health system. But then when you actually talk about what competencies you need in order to be able to conduct this kind of research, there's a lot of different components. And so there's improvement in implementation science, informatics, engagement and leadership, system science, research questions and evidence, ethics and implementation, research methods, and equity and justice that are all part of this. So the competencies for improvement and implementation science are to be able to reduce unnecessary variation in process and outcomes and confirm dissemination of new findings throughout the system. For informatics, the main competencies are knowledge of information systems and use of information systems to conduct learning health systems research to improve patient and health system outcomes. Engagement, leadership, and research management, the key competencies are to engage key partners in all aspects of the research and to lead and oversee learning health system research projects and teams. For system science, it's important to understand how the health system itself operates, as well as understand how to apply system theory to research and implementation. As far as research questions and evidence, I think it goes without saying that you need to be able to ask meaningful research questions, which is sometimes harder than it sounds, as well as evaluate the applicability of scientific evidence. As far as ethics, the research needs to adhere to the highest ethical standards, and quality improvement work also needs to adhere to the highest ethical standards. As far as research methods, the competencies are to conduct research in a complex health system and use correct study design and analytics to assess outcomes important to key partners. And then finally, health and healthcare equity and justice. It's important to know how to evaluate health equity and use learning health system methods to promote equity and justice in healthcare delivery. So why clinical pathways? Why are pathways the intervention of choice? Well, clinical pathways, as defined in the literature, are a structured multidisciplinary care plan. They're used to translate guidelines or best evidence into the local structure. They detail steps in the treatment or care of a patient, and the aim is to standardize care for a specific population or clinical problem. So a Cochrane review was completed back in 2012 that with about 28 different studies, if I recall correctly, and they showed at that point that there was a decrease in in-hospital complications, some improvement in documentation, a potential decreased length of stay, though no meta-analysis was done due to heterogeneity of the data, and potentially a decrease in cost charges. But again, no meta-analysis was completed due to heterogeneity of the data. So now this has been re-reviewed and recompleted, and it's now under review with Cochrane Australia. Another reason is if we think about how we reduce low value care, one of the, from this review that was done by Kalla et al., clinical decision support is something that can actually be very effective in reducing low value care. Well, what is clinical decision support? Clinical decision support seems fairly broad. Well, clinical decision support, as defined by these authors, was integration within the electronic health record, potentially order restrictions, like not being able to order the wrong type of test for the wrong type of patient, third-party consultations such as antimicrobial stewardship and help in picking the right antibiotics. And then finally, where my interest lies, widespread use of clinical pathways or guidelines. Thinking about this further, how does it help? How does clinical decision support help? It can encourage compliance with guidelines or protocols and provide clinicians information on evidence-based care when they need it, when they're taking care of patients. So now I'm going to talk about how I'm trying to work on building a learning health systems approach with the clinical pathways program. So in my mind's eye, we should be able to take external evidence as well as internal data, identify a problem at hand, engage our partners at Children's Colorado as well as nationally if necessary to try and design a change, implement that change into a clinical pathway or the program, and then be able to evaluate the clinical pathway or program changes. And then as that evaluation occurs, you're able to adjust the pathway and program to promote continual improvement, and then finally disseminating those findings outward. So these are, again, the competencies for the learning health systems researcher, but I also think it was a good way to talk about our clinical pathways program because we've touched on every piece of these competencies in some way or another. So from an improvement and implementation science standpoint, I was hired to oversee the clinical path, it was called the Clinical Care Guidelines Group at Children's when I went back from my education in Toronto. And quickly I realized we weren't implementing guidelines, we were implementing pathways. And this was housed under this new clinical effectiveness team where it was a hospital-driven initiative to improve care. And so the global aim for our clinical pathways program was a comprehensive strategy for initiation, creation, approval, and revision of clinical pathways based on evidence and measurement in a way that facilitates ease of use at the bedside. So when we sat down and thought about what our key drivers were, as we started this process, as I took over the program, we wanted something that had a predictable process, something that was accessible and usable, something that was easy to, some way of disseminating and communicating what we were learning, to be able to learn from it and measure, have some sort of measure of improvement, and then also identifying care gaps as well as important partnerships as we went forward. So this was one of our initial key drivers way back in like 2016 or so. And so we wanted to improve pathway development process, improve accessibility and usability, improve dissemination and communication, and strengthen measurement, as well as identify and address gaps and increase multidisciplinary partnership. And so these were some of the things that we thought about. For a predictable process, we needed more standardized content and templates. For accessibility and usability, we needed a way to be able to see it on our web platform, as well as be able to share externally. For dissemination and communication, again, we needed an internal and external facing website and a way to network with our community. And then we also wanted to be able to measure the program and individual pathways in some fashion. And then also we knew we needed to look outward to the important partnerships that were going to be interested in helping us move this work forward. So initially, from 2015 to 2018, we took our program from 33 pathways to 56. We went from no pathways on an external website to having all of our pathways external facing, though a couple lagged as we got some things ironed out. Our median time to completion went from 15 months to 5 months. And then our associated measures, 38% originally had measures. We got that up to 58%. And then we didn't know how many of our pathways actually had any sort of electronic integration in the beginning, and that was 67% at the end of this period. And though this was the start, we are continually improving and use a process improvement framework as far as continuing to move the program forward. From an informatics standpoint, it was in some internal key partner interviews that we conducted, there was definitely a call for a need for better integration of our clinical pathways into the electronic health record. There was a need for valuable measures of care, things that were important to both to the people across our institution. And then there was also a big need for data analytics and a way to track measures and be able to determine impact. So this became our burning platform for why we thought we needed some extra help. So our pathways at that point existed outside the electronic health record, and they were a static PDF and they weren't actionable in any way. And there was no way to tell if a child was being treated on the pathway or off the pathway. So in this light, we went forward with a third-party software solution that allowed us to build and maintain clinical pathway algorithms directly in the patient chart and provide our workflow to make them actionable during patient care. And the goal was to make it easy to work within the pathway to order and document care, to make it easy to do the right thing. And then finally, we wanted to be able to measure pathway and program specific metrics, and this made it more possible to do so. So this is a screenshot of one of our dashboards that we've created. This is for looking at migraines specifically, and this is length of stay in hours. And you can see that length of stay in hours for this pathway. So the pathway was originally introduced in 2021 and then updated in 2022. And you kind of get the feeling that the length of stay is increasing. And so when we looked at this, our pathway is specifically for migraine and dihydroergotamine use, or DHE. And so there's been a significant increase in the median length of stay for inpatients with migraines by 86 minutes. And that was significant. So if we go back and look at this, the migraine pathway is actually now keeping kids for up to as many as 20 doses of DHE. So we're actually meeting with the migraine and headache team currently, going back to the literature as well as our own data to see if there are different breakpoints, 12 doses or 15 doses potentially, to stop treatment with same or similar treatment effects, and seeing if if we can keep the pain scores about the same place but decrease the amount of time they're spending in the hospital. So this is work that's ongoing, but this is an example of how we're using our informatics system to impact care. As far as engagement and leadership, there's been a lot of work done in this area as far as our program is concerned. On this next slide, you'll see all the different areas that we currently have connections with and that we partner with on a regular basis. I'm going to spend my time talking about patients and families and then a national collaborative. So our hospital, one of my favorite people that I've met in the last few years is Kay Jenner, and she's one of the folks responsible for patient and family experience. And she runs a virtual parent group called The Table. And I was able to ask the different parents from the table a number of questions on a couple of different surveys, as well as trying to recruit families for participation in our program. So at this point, we have 18 families that are interested in participating. So in asking the bigger group as a whole on the table, we had 60 participants, and I was asking them questions about whether or not clinical pathways would be something that was important to them. And at that point, they said only 5% of parents and guardians knew if clinical pathways were being used in their child's clinical team. 70% would have liked to have known this information while their child was being cared for, and 93% would have liked to have a copy or access to the clinical pathway to follow along. 98% would have liked a handout or electronic visual that described the pathway steps. And 95% of parents believe knowing the steps in their child's care would have helped with communication with the clinical team. Finally, 88% felt it would help decrease their anxiety about what was going to happen next. So we definitely think there's room for us to grow in this partnership. And honestly, I feel like this is something we should have done a long time ago, but it's work that we're currently just getting up and off the ground. We're starting with quarterly meetings this spring. We're working to better understand how to partner with patients and families. And I think our thoughts as a team is we'll likely need to create a new tool or modify the pathway to fit their needs, but we're waiting for them to tell us what's going to actually work best for them. Because I think often the jump is to, instead of asking families what they need, is providing what we think they need instead of doing what's right for them. On the national level, we are starting a Pathway for Kids national collaborative, which is newly formed and being led out of Lurie Children's. And these are all the different institutions that are currently involved. And the thing that's nice about this group is it's a very multidisciplinary group with a variety of different backgrounds. And the clinical pathway programs at all these different places have similar challenges and opportunities. And it allows for sharing ways other hospitals have tackled a problem, and we can also work together on solutions. Currently sitting on the steering committee, and our first major, I think, task is to look for a sponsor organization. So we're taking this to other organizations to see if we can't get some sponsorship, with the idea that we eventually would be able to also look at our metrics and be able to compare to one another and how we're doing in caring for kids. So for the sake of this example, I'm going to talk about system science, research questions, evidence, ethics and implementation, and research methods, just because it works best that way to talk about it all together for this example. So again, we're hoping to be able to take external evidence as well as our internal data, identify a problem, engage partners in ways to design a change, implementing that change back into our electronic health record through the clinical pathway changes, evaluate those changes once they're made to see if we're making any difference, and then adjust the clinical pathway and program to promote continual improvement. And then and then also working to disseminate that outward once we're done. So I think one of the things that is interesting about clinical pathways is I think Typically, they're thought of as being very helpful and useful when you have you have a clinical practice guideline, you have a lot of evidence, you know what the right thing to do is, you know exactly what needs to be done. It's just a matter of getting it done. And that to me seems like, in this system science type thinking, a more simple or obvious solution. Well, with the pandemic and COVID-19, we had a really interesting opportunity to use clinical pathways in a different way. And I would say we were pushed to use them not so much in the simple and obvious way, but more in trying to tackle a complex system problem where we didn't know what we were facing. We didn't know what the problems exactly were, how to treat COVID-19. It was something that we basically started, and then we had to sort of look back and see how we were doing and modify our practice as we went. It was similar everywhere, but I think it was a novel way to think about clinical pathway use. So initially, we had a multi-system inflammatory syndrome in children, or an MISC pathway, that went live June 4th, 2020. So if you remember, the pandemic really started to kind of wind up in March, and by June we had this pathway and it was live. The question was, is IVIG alone sufficient for treating children with MISC, or is the addition of immunomodulator, infliximab in our case, helpful like it is for kids with Kawasaki's disease? We looked at 72 children in our institution cared for with MISC April 1st, 2020 to February 28th, 2021. The initial pathway recommended IVIG alone for initial therapy unless coronary artery dilatation Z-score was greater than 2.5. So just a little plug that all of our projects are either accepted and reviewed by our Colorado Multiple Institution Review Board, but we also have a quality board that is called Organizational Research Risk and Quality Improvement Review Panel at Children's itself. Typically, we tend to go through COMIRB more than ORCORP, unless it's something that's just within the hospital itself. So this is a research retrospective cohort study. We're looking at those kids who received IVIG alone versus IVIG plus infliximab, and noted that there was a decreased need for additional therapy in those kids who got the combination treatment, a shorter median ICU length of stay, decreased development of left ventricular dysfunction, and more rapid resolution of inflammation of their C-reactive protein at 24 hours. In addition, so based on that evidence at our local institution, as well as some evidence out in the literature that steroids in addition to IVIG was making a bigger difference, we changed our clinical pathway to recommend infliximab plus IVIG. And the IVIG, we found in looking at whether to give IVIG or infliximab first, that if IVIG was given first, it delayed the dosing of infliximab, and we ended up with more diuretic therapy, and the median CRP didn't drop as much. So the best way to do it was to give the infliximab before the IVIG. And so then you'll see in our data over time through our XMR charts that we were actually able to you can see where the pathway was implemented. You can see where our pathway changed, and you can see that our ICU length of stay did decrease. We do have some outliers further down in the data, which would be interesting to investigate, but we did overall impact, and we're able to show a shorter ICU length of stay. So now talking about equity and justice. So we are fairly new in the space of trying to think about how to address equity and justice in the clinical pathway program itself. But we currently have a project going on where our SMART aim is to assess and analyze all published clinical pathways with a diversity and health equity lens to evaluate for potential biases within standard care documents by December of this year. So we originally saw this in a presentation that Boston Children's gave on one of the Pathways for Kids national quarterly meetings, and really felt like this was something that we needed to address. And so we've been working on this, and their project was mainly looking at race and ethnicity bias. And so Dr. Chisholm Agman and Dr. Caitlin Widmer are helping drive this project through the Clinical Pathways program. And so far, when we have thought about this, we felt that it would be important to include in our discussion maybe something a little bit broader than just race and ethnicity. So Chisholm is definitely doing a lot of work to try and decide what exactly it is that we should be looking at and building a framework from the literature. So at this point, what we're looking at doing is building a framework that includes race bias, ethnicity bias, gender bias, biased language, a language bias, disability bias, social determinants of health, and bias specific to a disease or disorder. And we're working on reaching out to, again, Kay Jenner and the different family advisory councils, family partners that we have across the institution to help us in this work and make sure that we're not missing anything or leaving anything out, or that there isn't something that's more important to patients than what we're currently thinking about. We also have staff councils that we will also be talking with just to make sure that we are thinking of everything. So what lessons have we learned, and what are the next steps here? We've definitely learned that as far as improvement and implementation science, I have definitely learned that there's always something to improve and something to implement or re-implement or do it in a better way. Anytime you have new technology or improvements in your workflow that require revisiting or revising a process, you're always going back to that process and looking at, are there ways to do this better? Are there ways to streamline this? Are there ways that we can do this in a better way? I think there's also a need for both improvement and implementation strategies in a learning health system, and certainly in our clinical pathways program. I think it's been an interesting balance of what is improvement work or improvement science versus what is implementation science, and what are the boundaries between the two, and are there boundaries? I think I've learned a lot from one of my colleagues, Dr. Amy Tyler, in trying to look at the different faces of the same coin, which are improvement and implementation science. And I think trying to draw them together more than separate them is something that we're going to be looking forward to doing more. As far as engagement and leadership are concerned, I think it's really important to always have the patient's perspective at the center. And I think that's something that we didn't do from the beginning, and something that if I could go back, I would do differently and engage patients and families at the beginning and build them into this process. I basically inherited the program back in 2015, and we've done a lot to improve it and change it and make it better, but this is something that I think was an oversight on my part. I would definitely go back and have patients and families involved from the beginning. And I think it's also really important to stress that we shouldn't assume that we know best, or that that we know what patients and families need. And I think it does require some patience and understanding, as well as and making sure that they feel heard, and that we really can partner on this and come up with something that is important and valuable to patients and families, just like it is to healthcare providers and staff across our institution. And then I think from a national standpoint, there's been, a really great push for some collective collaboration to try and overcome barriers and opportunities that different programs have in different places, and working together to try and really understand exactly, what has worked and what hasn't. That's going to be different by context, but I think there's always things that you can share, even though they may not be exactly the same place to place. And then from a system science standpoint, I think what I have learned is that there's always the opportunity to use traditional tools in new ways. And I don't know that clinical pathways really count as traditional tools, but I definitely think that pathways have been used differently in the context of the pandemic, and really have sped sort of some good dissemination of best practices across an institution where often people didn't know exactly what to do. I think that was really an interesting, it was really interesting to watch and fun to be a part of. From a research questions, evidence, and methods standpoint, I think measurement is always harder than anticipated. I think even though, from an informatics perspective, we have a third-party software system, we're getting data from that third-party software system, we still have to build the denominator, and there's still a lot of work to do. And so it doesn't make it easy. And so I think it's important to partner with your key clinical partners and really work together to see what is the best way to get the data and get it analyzed. Because getting data and analytic support can be challenging. I don't know if other people find that, but definitely at Children's Colorado, it's something that I think is challenging for us all. And then I think it's also very challenging, but a good problem to have, that we need to work to put the data analytics and visualization together in a way that tells the story, that shows the opportunities for change. And that is not something that's necessarily easy to do. It's very important. And so being able to put the data in front of people in a way that tells the story and shows those opportunities for change is really something that I think we continue to work on. So what are some of our next steps here? So as far as improvement, implementation science and research, we are looking at the use of PRISM as a framework and evaluative framework to better understand the barriers and facilitators for implementation of clinical pathways with this third-party software system. We're looking to do interviews with providers, nurses, and patients, and was hoping to be further along with that. And then the respiratory surge hit. And so we are currently regrouping now that our patient volumes are back to more seasonal levels. And then hopefully using ERIC strategies for strengthening implementation based on those results. I think that we do a decent job of implementing, but I think it's somewhat scattered and not very rigorous. And so I think that's something that we could definitely do better using a model such as PRISM. And then I think we also need to work to move from diffusion to more deliberate dissemination. I think often we just say, okay, well, we're going to go present it at these different committees and email, X, Y, and Z sections, and that should take care of it. I think there's definitely a lot of more room for being much more deliberate and intentional about our dissemination plan in a way that makes more sense and potentially does a better job of getting the message out than what we are currently doing. An engagement and leadership standpoint, we are establishing a recurring and regular parent partner meeting to determine a plan for the next steps for the parent pathway engagement. And that also we are hoping to get done by December. And then we are always continually working on assessing improvement opportunities in pathway creation process and incorporating new partnerships and lessons learned and trying to test that in greater than 2 pathways by December. And then from an informatics standpoint, we are hoping to establish, measure, and visualize pathway-specific outcome measures for more than 2 pathways by December. And we definitely have a start on this, as you saw with our migraine and MISC data, but we will be doing this for a number of different pathways this year. And it's something that we continue to work toward. And then from an equity and justice standpoint, as I mentioned earlier, we're assessing and analyzing all of our currently published clinical pathways, which is about, I think we're up to about 75 with a diversity and health equity lens to evaluate potential biases within standard care guidance documents, also with the hope of getting some headway there by December. And with that, I'm happy to open the floor for discussion and questions.
Thank you so much for that great presentation around how you've been developing and implementing pathways. So one of the questions that came from Ashley in the audience is she wants to know which electronic health record you're using.
We're using Epic.
And then the application that you're using to integrate an Epic, is it all Epic that you're using?
No, that program is called Agile MD. And
Okay.
it's a third-party software system that basically implements the pathway directly into the patient's chart.
Okay. But obviously works well with Epic.
Yeah, it actually partners very well with Epic. And I would, we talked to Epic for a number of years about trying to develop something along these lines, and they have a product that they are working on. It just was very, it always was a little clunky, and it was based on best practice alerts for those of you that know Epic. And so it was very time consuming to build because every decision was a best practice alert. And so we just basically, our neighbor hospital, the university here, was already using Agile MD. And so we went over, looked at what they had, looked at the product, and really felt like that was something that we potentially would like to also try and use, and it's been great.
So while we're waiting for people to raise their hand or ask questions in the Q&A, my research is about involvement of families in the decisions about their care. And one of the ways that we do that is using patient decision aids that are really structure a decision so that families can be get informed and be part of how that decision is made. And so the best evidence around how to implement patient decision aids is we need to implement them in the path of care. And so this comes back to your pathways, because if I was at your institution, I would want to come and say, okay, let's flag where these decision points are. And when we can trigger the use of decision aids within that pathway or the engagement of patients and families. And so can you comment a little bit about how others like myself might be able to work alongside or integrate this type of research together?
Actually, I think it's a really natural partnering of information. And honestly, I think that's almost ideal in the fact that you would be able to potentially put those decision aids into the pathway itself as like trigger. This is where you need to talk to the family, and here's the decisions that needs to be made let's, take this and talk to the family and decide. And honestly, that's a great idea, as a way to, really point out where where those decision points are. And so it's then beyond you and the research team, it would be something that you could implement system wide, um, though, with a little effort. I think that that is a really interesting idea and something that I hadn't thought of, and a great idea. I think, along with it being a tool for them to for parents and families to understand where they are in their care, but also to say, and then this is where we actually need to make a decision. And here's the decision that needs to be made. And here's a decision aid to help in that decision making.
Yeah. Oh, well, maybe we can have a conversation offline.
Yeah, I
Somebody-
would love to.
A question from Kristen. Have you had any challenges with clinicians accepting use of clinical pathways as they were felt to take away clinician autonomy in clinical decision making? And if so, how did you overcome that? So it's around the challenges with engaging clinicians.
Yeah, we definitely have. In fact, we did a round of qualitative interviews with both hospice and ED physicians, specifically around that question as to what are the benefits of clinical pathways and what are some of the pitfalls. And I definitely think that was something that was heard loud and clear is, I don't want, it's taking away my autonomy potentially. I'm not able to make the decision. And I think we saw more of that earlier on. I think the thing about clinical pathways is it's not set in stone and it's not something you have to do. And I'm not telling you that it's always the right way to practice medicine for a certain patient. And so I think, it's always really valuable to those folks saying to them, you're probably right. You're sitting in front of the patient. And there's the 80-20 rule. 80% of the time, the pathway will probably work. There's going to be 20% of the time where it's not going to work and you probably need to do something differently. And, as the clinician, you are the person who knows best what the patient is and whether they fit into that inclusion and exclusion criteria of the pathway. And if it's not working, I think that's something that we're definitely working on at our institution. Dr. Joe Grubenhoff is leading diagnostic safety at our institution. And that's definitely something that we're working on, partnering together on, is how do we use clinical pathways in a way where we're complementing decision making for physicians and clinicians and not hindering their decision making by different potential biases. And so it's definitely come up. And I do think that you have, the freedom to do something different. And that's what I generally say is, if you think something different is going to work better. And I think down the road, what is going to be really important about this is being able to look at those differences. Like, well, in this case, they didn't follow the pathway. Was the outcome better or worse? What did that patient look like? And is there some reason that it was potentially better, or did they not quite fit the pathway? And really learning from that to influence how the pathway changes.
Thank you. Sabrina Gill has a question for you. Can you tell me more about your experience using the equity and justice pathways? Are you able to collect data also within the pathway?
Yeah, so we are able to collect data from within our pathways as far as we can tell, like orders that come from our pathways. So any medications that are ordered through the pathways, labs, imaging, those are all things that we can tell. And so we're like so dipping our toe in, like we're not very far along in this, but as part of that, as part of the process of analyzing all of our different pathways to see if there's actual bias in the actual language of the pathways. I think the other piece of this is trying to go and look at the outcomes for different kids, using race, ethnicity, language, those different things to see if we are impacting kids differently because of who is and who isn't placed on the pathway. We've just barely started that work. We have looked at migraine very superficially, and from, superficially, it seems like there are not differences in race and ethnicity as far as who is being placed on the pathway and who is not, and who is getting that care. But that's definitely something that we continue, hope to continue looking further into.
Thank you. Carolyn Gall, Casey is asking, how familiar are patients and carers in Canada, well, or this could be in your institution, that pathways exist and that they may be guided by a pathway?
So when we asked, very few were aware. I think I think initially it was, thinking back to the survey, I think 5% said that they were aware of some sort of pathway being used for their kids. So not very many, which is, more impetus to continue to try and strive toward this work, because I think, if we can all be, if we are all on the same page, when we have a shared mental model as to what's happening, with their kid in their care, and they also have the same, knowledge and mental model of what's happening, we're going to be in a better spot. And I think a lot of times, we are not on the same page, and that definitely takes a lot of time and energy, which is important. And description. I think the other piece that I've heard from families that we're going to have to figure out in the, as we move along here is, well, my kid is really complex and wouldn't fit into this pathway. And so what do we do for complex kids who aren't going to necessarily fit the pathway or the inclusion criteria? And I think that's a really fair statement. What do we do? And how do we approach kids that have more complexity? And is there a way to integrate them in a way where we can standardize their care?
Yeah. So in the pathways, if I remember correctly, you have them all on a website.
Mm-hmm.
So does that mean that patients and families can access them just like
Mm-hmm.
clinicians can? I see you saying yes. And then do you have a patient version, or is it plain language so that everybody can look at the same pathway and understand what's involved?
At this point, we only have the one version, but I think that is one of the projects that we're going to tackle in this next coming year is what is it that patient and families want or need. I think similar to you, my jump is, oh, well, they need a plain language summary, or they need a different tool, and I just want to start building it. But we haven't even gotten as far as what they think they need yet. And so I think it's going to take some legwork to actually figure out what's going to work best. And that's why I say I have to be patient, because I often just want to be like, oh, I see a problem, let's solve it. And let's keep moving. But I'm going to solve it in a way that is not going to be patient and family focused like I want it to be. So we're definitely taking the time, really trying to make a really solid partnership with these families to better understand what exactly they do need. And then we will work to implement that once we better understand what it is that they think is going to be best.
Another question I have is about the magnitude of a pathway. Like, I come from adult cancer, and so I often think about breast cancer and the pathway of, surgery and then chemo and radiation, and like there's a whole pile of steps in that pathway. And then the example you showed was migraines and hospital admission with a specific treatment, which seems like a very narrow type of pathway. So I was just wondering if you could talk a little bit about the complex, like the magnitude of a pathway and how that is determined or works?
So we definitely have that example is very narrow. You're correct. We definitely have pathways where there's like 4 or 5 algorithms all for the same pathway. So um fever in infants is probably a good example. So we have, you know, depending on age, there's something that happens differently for 3 different age groups. And then you have to think about HSV, and then and so we definitely have pathways where it's called an accordion, where we have a number of those algorithms all stacked together. Musculoskeletal infection is another one where we have a diagnosis pathway, a treatment pathway, and then sort of like follow-up decision-making type pathway. And so our algorithms all within the same pathway. So I would say, and we're currently tackling a revision of asthma, which doesn't seem like it would be tough, but that too has some different nuances depending on whether you're, you know, outpatient, inpatient, ICU, ED, where exactly you are. And so I definitely think that the pathways can get fairly specific, and I think there's a way to gather them there's a way to put it together in a way that makes sense, so that it's not just this overwhelming mess of arrows. But that is definitely something that I think we are learning over time too. And our initial MISC pathway was kind of a was like, there's arrows everywhere. We got to figure out how to like pull this together and what exactly we're doing. And so I do think that it is something that can take on complex problems. I think the way you break the problem down and tackle it within the pathway to make it understandable is important.
And then I'm going to ask you the big question around cost, right?
Right.
Because it costs to develop the pathways, but what I'm more interested in is around the learning health system, because it costs to monitor and feedback. And so can you
Yes.
just talk about like the budget or how you justify that piece of it?
Yeah, no, I think that therein lies like the difficulty, I think, in doing this work. So, you know, I think part of it is if you put together a pathway and you have no way of knowing if care is better, worse, or the same, in my opinion, it doesn't seem like it's worth doing. And the fact that it feels good doesn't seem like that's the right answer. So yes, I do think that there's, you know, we have to be able to monitor and be able to say that this in some way is impacting care in a positive way, or why are we spending all this time and money and effort in doing this, right? We have been able to show some cost savings in bronchiolitis with decreasing X-ray bronchodilator use. In the past, we've been able to show some cost savings in appendicitis with not getting so many CT scans. And so I think there are definitely ways to show what we are doing makes some sense from a hospital standpoint too, as far as cost savings. But I'm not at this point able to say, on the whole, this clinical pathways program is saving you money, right? If I could, I think I'd be ready to retire. But I think that that's definitely where we're headed. We're just not able to do that just yet. But I do think that this is, you know, to say, and I think the other piece of this is building a learning health system. I think the thought is as well, I'm going to build this learning health system and then I'm going to use it, and that's how this is going to work. But I think what I'm learning is that there's a lot of partnerships across the institution. Like, you know, the infectious disease doc just pulled a bunch of data on community-acquired pneumonia. What can we do to partner with her to sort of look at what we're doing from a pathway program standpoint and say, is it working? Is it or is it not? Instead of, definitely we're trying to put the infrastructure together to be able to put this learning health system together. But I think we're also going to have to say, well, you've got data, let's see what your data says, and let's use your data and use, be smart about those partnerships, because I think that's important too. It shouldn't be, my hope is that there is ownership outside of the Pathways program for these different illnesses and conditions and people wanting to impact care and make it better. And we can partner together on making sure that that's actually happening.
Okay. And one last question. Shauna is asking, can you say more about the learning system aspect in terms of what has supported learning flowing back for action and what roles have supported this process? So it's really around the feedback mechanism and whether or not it's been able to be successful with implementing subsequent change.
Yeah, so I think a good example is our musculoskeletal infection pathway. We, Dr. Grubenhoff in the emergency department has looked at what are the most frequently missed diagnostic opportunities in the emergency department, and musculoskeletal infection is number 2 on the list. And so we're basically taking what he has learned and now going back and modifying the pathway to try and put those changes in order to try and help people make the right diagnosis in the right timeline. So there is that feedback loop. MISC is another good example where we changed the medications. I think migraine, another one where we think that the change that we made is making people stay a whole lot longer. So we need to go back and make those changes and then look at the data again. So I don't know that I have a great example for, we've looked at the data for 17 years and this is the change. We definitely, bronchiolitis has been a long-standing clinical pathway that we've had, and we were able to show that we definitely have stayed, our system has stayed very steady throughout most everything. And then it was very interesting because in the pandemic, it goes out of control, right? And then now that we're sort of hitting the end of the pandemic, the system is going back into control, which is really interesting. So I think that is what we are driving for. But I think we're just early stages. If somebody else is able to do it in a much better way, I would love to hear.
Well, I need to cut it off at this point and thank everyone for attending and for your excellent presentation. Just a reminder to complete the online evaluation form that Megan's placed the link in the chat. Just to let you know, the next webinar is planned for Thursday, March 16th. This has been moved back a week from March 9th, so March 16th. And Dr. Leigh-Anne from McMaster University will be speaking about pilot versus feasibility trials in implementation. So looks like a good one to tune into. So thank you for attending, and thank you so much, Dr. Bakel, for your presentation today.
Thank you.
Thank you, Dr. Bakel, and thank you so much, Dr. Stacy, for moderating for us today. Take care, everyone.